Well, we see a number of advantages, and first you might want to divide the world into different geographical areas. If you look at developed countries, then I think one of the biggest driving reasons could be the cost of the infrastructure that is being used, because in developed countries we usually have access to an OR, but an operating room comes with a lot of related costs. And cross-linking is a rather lengthy procedure, in general takes as much time as 2 cataract procedures would take in one go. So taking the cross-linking procedure out of an expensive infrastructure into a less expensive infrastructure would help drive down the global costs of the procedure. Now this accounts for developed countries. If you look into developing countries, then we speak about giving access to a technology that otherwise would not be accessible readily. Let's take remote areas of Bangladesh where the eye doctor never gets close to an operating room, but what every healthcare professional in our field has is a slit lamp. It's the common denominator of our profession. So where is a slit lamp? There can be cross-linking. In other words, democratizing access to the technology and providing the access for all. That's a question we hear a lot. The short answer is yes. But if you look at the original Dresden protocol, which would take 30 minutes, this certainly would not be feasible at the slit lamp. Now we have 2 main indications for performing cross-linking. It could be either keratoconus treatments or infectious keratitis treatments. Cross-linking for keratoconus has been performed for more than 20 years now, and the currently widely accepted protocols perform cross-linking in any setting, whether it be at the slit lamp or in an operating theater in the lying position, safely at 8 to 10 minutes. So if you are confident that your patient will be able to stand still at the slit lamp for 8 to 10 minutes, you could perform cross-linking at the slit lamp from now on. If you look into keratitis protocols, we now have functioning protocols at 4 minutes only, because we can highly accelerate the treatment. Keratitis treatment is oxygen independent, and 240 seconds at the slit lamp should suffice, and this is, I think, very realistic. But it also means that you need to identify your patients and ask yourself the question, will this specific patient be able to stand still for either 4 keratitis or 8 to 10 minutes as an ectasia? And I for sure would never try to cross-link a teenager or a child simply because they would never stand still for so long. The risk of infection is the second most common question we get. Well, I would like to point to the fact that we know much more about cross-linking mechanisms than we used to do 15 to 20 years ago. In the early days, we thought all CXL does is stiffening the cornea. We know now that there are 3 additional mechanisms that come into place in every single CXL procedure, whether it be keratoconus or keratitis. It doesn't only stiffen, CXL increases the resistance to digestion, it stops the replication of any living cell within the cornea by intercalating with the DNA and RNA, and it also creates a huge amount of free radicals, which translates into stress to cellular membranes. It just unspecifically kills any living cell. And what many forget is this is not only happening in keratitis treatment, it happens in every keratoconus treatment. At the end of a keratoconus treatment, your cornea is sterile. So after these 8 or 10 minutes spent at the slit lamp, you look at the sterile surface. It's even more sterile than the unfortunate patient who comes in to your normal routine consultation telling you, my little kid has scratched my cornea, look, it's all scratchy and it's an open surface. That cornea is more infected than the cornea at the end of the procedure. And this is why we are very confident that we shouldn't see any increase in related complications when we take the technology to the slit lamp. This was one of the other issues my colleagues are worried about. What happens if you are in the upright position? Wouldn't riboflavin distribution change due to gravity alone? We tested this and we published the data 2 years ago. It was a straightforward experiment where we determined riboflavin distribution in a vertical position, in the upright position, and even after 60 minutes, a full hour of vertical positioning, the gradient between the upper and the lower cornea in terms of riboflavin concentration was 5% only. And we never need 1 hour for treating. We need 4 to 10 minutes. So you're totally safe with regard to riboflavin distribution. That's another good question. Well, my counter question would be, why would the eye behave any differently whether you are in the upright or in the lying position? Because the technical settings used are absolutely identical to everything that has been used in the past 20 years in the lying position. And we speak of roughly 200,000 procedures performed every year. The only difference is the positioning. Riboflavin distribution is not affected. The UV beam certainly it doesn't matter to any UV beam whether it's directed in a horizontal or in a vertical manner. So I do not expect any difference in the outcomes that is related to the positioning alone.